It's been almost 2 months for me in AIIMS Bhubaneswar, and I've come a long way trying to remember where the anesthesia and pediatric surgery OPD are up to guiding patients as to what to do next. To be honest, I started with just this book, trying to remember what happens, how to adjust to it. Coming straight from MBBS to an MCH course means you are a lot more behind everyone else than you think. What is a general notion for everyone else is completely new idea for you. So for example, when they know how to treat hydrocele, hernia in MS itself, you are like, okay, these are the cases that I've seen in internship, but I've never watched in on them. And now they are treating meningoencephaloceles and all those fancy things like Hirschsprung disease and all, and you are like, yes, I've seen them in the textbooks, but this is the first time seeing the case in real life. Okay, let's start from the beginning. Here's how day in my life looks like. There are 3 parts of the duty of a resident. You either go to the OPD or the ward or the OT, depending on the duty schedule that you get every month. So for example, when you either way, if you are in OPD, ward or OT, you need to be in the ward for the morning rounds, which start at 8 o'clock. So from 8 to around 8:30, 9 o'clock, we have morning rounds where we discuss each of the cases and try to learn a bit more from the senior residents that they are there. Afterwards, if you are posted for the OPD, you go to the OPD. If you are posted for the ward, you go to the ward, and as such. In OPD, the kind of cases that you get include hydrocele, hernia, phimosis, prepuce irradiations, cystoscopy, bladder extrophy, ectopic kidney, Down syndrome, neonates, etc. 50 to 60% of the whole pediatric surgery is urology itself. So you'll deal with a lot of urology cases. In OPD, you are studying under a consultant plus minus a senior resident, in which they guide you as to how to examine a patient, how to approach its clinical diagnosis, how to address the investigations, and how to plan for the operation theaters. I'm still a very young green kid and I don't know a lot of things, but yes, I am proud to say that I'm trying my best to catch up. Afterwards, after the OPD is done, you go back to the ward and check if the ward resident has something to do, and you finish that work and go back. It usually is around 8 to 9 o'clock when you go back to the room. If you are a ward resident, after the morning rounds, you get a list of things that you are supposed to do, including sending the samples of the patient, USG, echo, etc., pre-op patients, and the post-op orders that are need to be done, like washing, stoma, etc. Again, I don't know a lot of things, so I may be in the wrong, and I may use the wrong terminologies in a lot of them, but I'm just giving an overview from a junior resident point of view who's just joined in. So that's it. You all the time you are staying under the guidance of senior residents, so you don't mess up a patient. You are under the watchful eyes of that resident, and you learn a lot of things as and when the days go by. Other than that, I have become good at preparing discharge summaries, so that's something I'm proud of. Other than that, there's case sheets, daily orders, and stuff like that. If you are posted in OT at 9 o'clock, you reach the OT, you take the first patient in, you scrub in, and you assess the consultant and the senior resident in the procedure. Again, all I'm getting to do right now is holding the retractor and the forceps and taking a few stitches and all that. But judging by the qualification and the skills I have, that too is a lot much. I try reading the operations, I try reading the procedure, the diagnosis, and about the disease from the books, but it's quite a lot overwhelming than I thought initially. But I know I'll catch up. It's a 6-year course for a reason, right? I'm hoping that the future self that is watching me is laughing at how incompetent I am and is proud that how much I have grown till now. There are a lot of interesting cases. We take basic histories in ward, do the examination, review the vitals, do the post-operative care, medications, and plan for follow-up. It's a tertiary care, so we usually get only referrals from pediatric medicine or other hospitals. So I guess the diagnosis part of it is a bit less, but other than that, it's great. This is something that I've learned over the course of 2 months, that every stitch that you make, every incision that you take, and every word that you say is going to stay with the patient and the family for the rest of their life. So you have to be very careful with your approach, with your words, and you have to be very kind and gentle with the kids, because everything that you do is either going to be a pleasant surprise or a trauma for them for the rest of their lives. So this is the kind of branch that pediatric surgery is. You have to be delicate. You have to take care that you are not rude to the patient no matter how exhausted you are. There are a lot of emergency cases as well, including ICD insertion, foreign body in the intestines and stuff like that. We get to watch them in casualty. We usually go for a wait and watch approach, but whenever there is required, we go for an emergency surgery as told by the consultant under which we are working for. Overall, for AIIMS Bhubaneswar, hands-on it is a lot. Senior residents are quite well. Junior residents and my seniors who are JR2 are also very helpful and kind. I'm having fun. The thing is that it's still overwhelming for a person who's coming all the way from there to here. Learning Odia, learning Bengali, that's also a part of the curriculum for me now. So, tikke Odia bujo. Like, that's how much Odia I know for now. As for Bengali, I know things like Bhalo, Vyatha, Banti. Like, I am trying to learn the basic words necessary for the doctor. I think that's the approach one should get when you are in a new setting, new clinical setting. So right now my focus is to educate my brain through my hands, and that's what one of my consultants told me. So I try reading a topic, I try going back to the ward, to the OPD, to the OT, and try seeing the patient there is, and try to understand and correlate what is given in the theory to the practicals. It's an MCH branch, so most of the reading is from higher end books as well as the research papers. So again, काफ़ी कुछ दिमाग में नहीं जाता है, but trying is a part of the process, and I'm sure over the course of days I'll understand it. Other than that, there have been Chiasma, the annual event that I'm sure you have seen on my Instagram story. In that there was concert, there was DJ and stuff like that, and we enjoyed that a lot too. So social life bhi kafi hai. Even though I don't show it on Instagram, there's quite a lot of social life going on. Then let's come to the academic sessions that happen twice a week for an hour or 2 hours, in which the senior resident or the consultant presents a case or a research paper or a case series or something like that, over which the discussion happens and the questions are given, which is also a great refresher of what the current technology is going on, what the current advancements in the medical field are going on. So you get to stay with the recent approaches on the same disease diagnosis and get to treat the patient in the best way possible. I especially like the tumor boards that happen every twice. I especially like the tumor boards that happen every month, in which we discuss a very complex case. For example, this time it happened to be a synovial sarcoma of the lower limb, where a multidisciplinary approach is taken for the surgery of that patient. It's very cool, and it's something that I am glad to attend to. According to the syllabus, according to the academic syllabus that I've been given, I'll be in the pediatric surgery department for an year, and from next year I'll go to a 1-year rotation through various departments, including general surgery, urology, neurology, etc. And then I'll come back in pediatric surgery, and then I'll stay there for 4 years. In these, there are 2 exams, one after I come back after 2 years and one at the end of 5.5 years. I need to pass both the exams. Other than these exams, there are semester end exams each in every 6 months, as well as the biostats exam that happens. I don't know a lot about what all these are, but I'm sure I'll learn over the course of time. Again, I'm saying that a lot because that's what I'm hoping for. So about pediatric surgery as a whole that I've learned for now. Pediatric surgery, as the book says, is the last bastion of general surgery, where you treat everything right from the brain up to the toes. So in brain, we usually put our hands in occipital encephalocele and the sacral meningoencephalocele. So in brain, we usually put our hands in the occipital encephalocele and the sacral meningomyelocele. These 2 operations I saw yesterday only. Then in the intestine, we do lap cholecystectomy, lap pyeloplasty, as well as open cholecystectomy and the pyeloplasties, reimplantations, appendectomy, stroma creation, Hirschsprung disease, etc. So many of the things of the intestine, as well as lungs, including bronchopulmonary sequestration case, anything other than the heart, to be honest. We also do decortication that I saw last week, I guess. In the urology part, we do literally everything, right from phimosis up to extrophy of the bladder. We sometimes take help from other sister departments like plastic surgery, urology, etc. Then in the lower limbs, we do tumor removal, dermoid cyst removal, etc. Other than ortho, brain and cardio wala part, we do most of the things for pediatric surgery. So we are we have to be well versed with every system there is in the body. It's a relatively new discipline for an MBBS student in India. So I believe that as a MBBS graduate, you need an exposure to pediatric surgery, even if it is just for a week in internship. So maybe after seeing this video, one of the people will try and decide to integrate it in the curriculum program or something, because it is very necessary for an MBBS student to know what ways he or she has up in the future to go ahead on that. This video has been very abstract, but I did want to put everything that I've been through in the last 1.5-2 months and show you how actually this super specialty and this college is for you all, so that maybe one of you will be my junior next year. I'm hoping to see you here, and I'll be really glad that we work together in this department. That is all. If you want to know anything about it, please do let me know. Other than that, for those who are afraid to take an MCH course, all I want to say is that it takes 4 to 6 weeks of uncomfortable isolation to discover who you are. So take the leap. I'm sure you will not regret it. This is Abhijeet signing out. See you in the next video. Bye bye.